Acute coronary syndrome is an umbrella term for conditions caused by a sudden, significant reduction in blood flow to the heart muscle, or myocardium, potentially leading to myocardial ischemia. It represents a spectrum of urgent cardiac conditions, all stemming from the acute disruption of a coronary artery plaque and subsequent blood clot formation. The three main types within this spectrum are unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. The core pathophysiology begins with the rupture or erosion of an unstable atherosclerotic plaque within a coronary artery wall. This rupture exposes the plaque's lipid core to the bloodstream, which immediately triggers platelet adhesion, activation, and aggregation, along with activation of the coagulation cascade. The result is the formation of an intracoronary thrombus. The degree to which this thrombus occludes the artery determines the type of acute coronary syndrome. A complete occlusion typically leads to an ST elevation myocardial infarction, causing transmural or full-thickness heart muscle ischemia. A partial or subtotal occlusion leads to either a non-ST elevation myocardial infarction or unstable angina, resulting in subendocardial ischemia. The clinical presentation centers on chest pain or discomfort. This pain is typically located under the breastbone or substernal and often radiates to the left arm, neck, jaw, or back. Patients describe it as pressure, squeezing, heaviness, or tightness. In a myocardial infarction, this pain usually lasts more than 20 minutes, while in unstable angina it may be more variable. Associated symptoms include shortness of breath, diaphoresis or profuse sweating, nausea or vomiting, lightheadedness, and palpitations. It is crucial to recognize atypical presentations, which are more common in women, diabetic patients, and the elderly. These may include isolated shortness of breath, epigastric pain mimicking indigestion, profound fatigue, or even syncope. Diagnosis is based on the universal definition of myocardial infarction, which requires at least 2 of 3 criteria. The first criterion is clinical symptoms of ischemia. The second is characteristic electrocardiogram changes. The third is a rise and/or fall of cardiac biomarkers, with cardiac-specific troponin I or T being the preferred and most sensitive marker. Classification into the 3 types depends on these findings. An ST elevation myocardial infarction is diagnosed when there is new ST segment elevation at the J point in 2 or more contiguous leads on the electrocardiogram. A non-ST elevation myocardial infarction presents with electrocardiogram changes like ST depression or T-wave inversion, along with a positive troponin level. Unstable angina involves ischemic symptoms without a rise in troponin, though the electrocardiogram may show transient changes. Initial management in the first 10 minutes, whether in the emergency department or pre-hospital setting, follows the principle that time is muscle. General measures are often remembered by the mnemonic MONA-B. This stands for morphine for analgesia, oxygen only if the patient is hypoxic, nitrates such as sublingual nitroglycerin, aspirin 162 to 325 milligrams to be chewed, and a beta blocker if there are no contraindications like heart failure or bradycardia. Dual antiplatelet therapy is initiated by adding a P2Y12 inhibitor, such as clopidogrel, ticagrelor, or prasugrel, to the aspirin. Anticoagulation with an agent like unfractionated heparin, enoxaparin, or fondaparinux is also started. For ST elevation myocardial infarction, the strategy is rapid reperfusion. The goal is to restore coronary blood flow as soon as possible, with a target door to balloon time of less than 90 minutes. The gold standard treatment is primary percutaneous coronary intervention, which is emergency coronary angiography, followed by stent placement at the blockage site. If this intervention is not available within 120 minutes, then fibrinolytic therapy or clot-busting drugs like alteplase, reteplase, or tenecteplase must be used. These have absolute contraindications, including active bleeding, recent hemorrhagic stroke, or suspected aortic dissection. The management of non-ST elevation myocardial infarction and unstable angina begins with risk stratification using validated scores like the thrombolysis in myocardial infarction score or the Global Registry of Acute Coronary Events score. High-risk patients, such as those with recurrent ischemia, signs of heart failure, hemodynamic instability, or a high-risk score, undergo an early invasive strategy. This means coronary angiography within 24 to 48 hours. Low-risk patients may be managed with an ischemia-guided strategy, focusing on medical therapy and later stress testing. Medical therapy for these types includes dual antiplatelet therapy, anticoagulation, a high-intensity statin, a beta blocker, and an angiotensin-converting enzyme inhibitor or angiotensin receptor blocker. Complications of an acute myocardial infarction can be severe. Arrhythmias are common, with ventricular tachycardia and fibrillation being the most common cause of early death. Other arrhythmias include bradycardias and various degrees of heart block. Mechanical complications often occur 3 to 5 days after the infarction. These include ventricular septal rupture, papillary muscle rupture leading to acute mitral regurgitation, and free wall rupture leading to cardiac tamponade. Heart failure and cardiogenic shock can also develop. Inflammatory complications include pericarditis, either early or delayed, as in Dressler syndrome. Thromboembolic complications can arise from a left ventricular mural thrombus, leading to systemic embolism. Following the acute phase, secondary prevention and long-term management are critical to prevent another event. Lifestyle modification is foundational and includes mandatory smoking cessation, enrollment in cardiac rehabilitation, adopting a heart-healthy diet like the Mediterranean diet, and engaging in regular exercise. Essential pharmacotherapy typically consists of lifelong aspirin, a P2Y12 inhibitor for 6 to 12 months after a percutaneous coronary intervention, a high-intensity statin, a beta blocker, and an angiotensin-converting enzyme inhibitor or angiotensin receptor blocker, especially if the left ventricular ejection fraction is reduced. An aldosterone antagonist may be added for patients with a left ventricular ejection fraction less than or equal to 35% who have symptoms. Aggressive control of all cardiovascular risk factors, including hypertension, diabetes, and dyslipidemia, is non-negotiable. In conclusion, managing acute coronary syndromes is a continuum of care. It begins with pre-hospital recognition, moves to rapid in-hospital intervention, and transitions to diligent lifelong secondary prevention. The keys to saving myocardium and lives are early diagnosis, prompt reperfusion for ST elevation, myocardial infarction, and appropriate risk-based intervention for non-ST elevation, myocardial infarction, and unstable angina. Post-discharge, the focus shifts to rehabilitation, medication adherence, and comprehensive risk factor control to prevent recurrent cardiovascular events. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.